Dear Chairman, my dear colleagues, first I must say كل سنة وانتم طيبين, and thanks Professor Ines for her effort, and thanks Amr for uncovering some deficits in the guidelines of or the consensus of fasting Ramadan, because we need more studies on a larger scale, not for 17, 18, or 70 or 80, because the evidence of science should be with large studies. I will not say that the cardiovascular patient should fast or not fast. I will undercover some important points and, that we will discuss later in order to update our consensus of last year, with which I share with. The recommendations for patients with cardiovascular disease for fasting Ramadan, here as we see, the introduction, first here, the recommendations on safe fasting is very important. Exists for patients with some chronic conditions such as diabetes mellitus. Guidance for patients with cardiovascular disease is lacking. And studies on the safety of Ramadan fasting in patients with cardiac disease are sparse, observational, of small sample size, and have short follow-up, misfortunately. All patients who are fasting should be educated before Ramadan, and this is mandatory, on their risk and management, including the risk of dehydration, which is very important for thrombosis, for example, fluid overload, and terminating the fast if they become unwell, and reviewed after Ramadan to reassess their risk status and condition. The epidemiologic studies show that many of the diabetic patients want to fast in Ramadan, as we saw from Professor Ines in the first slides. Ramadan fasting for diabetics is associated with some risk. These are hypoglycemia, which is dangerous for the cardiovascular patients with prolongation of the QT interval that causes arrhythmia and sudden deaths. Hyperglycemia, dehydration, and increased risk of thrombosis. Physicians need to identify the diabetic patients who are eligible to fast and also arrange their medication. A fairly small group of patients with cardiac conditions should be advised to refrain from fasting during Ramadan. This includes patients with acute cardiac illness, like acute myocardial infarction, AMI, and acute coronary syndrome, ACS. Patients with uncontrolled hypertension requiring multiple dosage during the daytime should be counseled against fasting, and patients with severe congestive heart failure requiring higher doses of diuretics should also refrain from fasting. This is the consensus of the last year, 2021, we share all together. And we see here the very high risk patient. We have here the recent vascular thrombotic events 6 months before Ramadan, like stroke, transient ischemic attack, acute coronary syndrome, acute peripheral arterial ischemia, DVT, or recent revascularization procedure. This is very dangerous to fast. This is the very high risk patient. And for high risk here, heart failure, NIHA class 1 and 2, stable atherosclerotic cardiovascular disease as a stable angina, or chronic peripheral arterial disease. I'd like to say here that this was last year, but the guidelines are changing, always changing in the cardiovascular medicine. Because this misnomer, there is no stability. There is no stability in the acute coronary syndrome or stability in heart failure. Diabetic patients who want Ramadan fasting should have a risk identification to low, medium risk, high risk, and very high risk in order to make their fasting. So, before we start to advise the patient, we have to study the 2021 European Society of Cardiology Guidelines on Cardiovascular Disease Prevention in Clinical Practice, which was published in last August. Here we can see that patients with established atherosclerotic cardiovascular disease and or diabetes mellitus or moderate to severe renal disease and or genetic rare lipid or blood pressure disorders are to be considered at high or very high cardiovascular risk, and this is class 1. It means there's a big evidence and data that the patients who have an atherosclerotic cardiovascular disease is considered a high or a very high risk depending on the risk stratification. Then systemic global cardiovascular risk assessment come next to assess, which is recommended, and this is class 1C, in individuals with any major vascular risk factor, like family history of premature cardiovascular disease, or familial hypercholesterolemia, which is missed and diagnosed, and cardiovascular risk factors such as smoking. Most of the Egyptians are smokers, reaching about 75% of the population, arterial hypertension, diabetes mellitus, raised blood level, obesity, or comorbidities increasing the cardiovascular risk. Those patients should have a systemic global assessment. When they show the risk or the score risk in the European Society of Cardiology, we can see here one color is red, orange, number 2, yellow, number 3, green, number 4. There are 4 categories of the score risk categories. The red one, including Egypt here, ان انت بتيجي بتستعمل الريسك سكور بتاع very high risk. For example, the score system used for the European with the green, this is intermediate or low. We should not apply it to the Egyptians. And for also the yellow here, this is the high risk, should not be applied to the Egyptians. If you want to make the score, وده موجود على جوجل وتدخل على السكور سيستم بتجيبه، بتجد ان لازم تستعمل الرابع ده اللي هو الفورث or the very high risk, because we are a member of the European ECC. What does it mean? Some countries have a cardiovascular disease mortality rate more than 350 per 100,000, and the high risk chart may underestimate the risk. These are Azerbaijan, Belarus, Bulgaria, Egypt, Georgia, Kazakhstan, Kyrgyzstan, North Macedonia, Republic of Moldova, Russian Federation, Syria, Tajikistan, Turkmenistan, Ukraine, and Uzbekistan. دول كلهم نستعمل لهم الريد كولر اللي هو بتاع السكور، ما نستعملش بتاع اللو ريسك تشارت او الهاي ريسك تشارت اوف يوروب، وده اللي بيغلطوا فيه كتير وهم بيعملوا السكورنج على البيشنتس. So Egypt here is in the very high risk score, the red one. How to use the risk estimation chart? To estimate person's 10-year risk of cardiovascular disease, death, we should find the table for her gender, smoking status, age. Within the table, find the cell nearest to the person's blood pressure and total cholesterol. Risk estimates will need to be adjusted upwards as the person approaches the next age category. And as we see here, this is for women and this is for men. This is the score cardiovascular risk chart, 10-year risk of fatal cardiovascular disease, high risk regions of Europe, the score chart for European population at high cardiovascular risk. هنستخدم الأحمر، بتشوف أول حاجة الجندر والage، سموكر ولا نون سموكر، وتشوف البلاد بريشر بتاع البيشنت والتوتال كوليسترول، وبتقدر انك تحدد where this patient from cardiovascular disease. وما تتعبش نفسك بيه، موجود applying على جوجل، بتنزله كابليكيشن على الموبايل بتاعك، بتحط كل الكلام ده وبيديك البيشنت ده في ايه. There are more factors modifying this score risk more factors. Social deprivation, the origin of many of the causes of cardiovascular disease, obesity, central obesity as measured by the body mass index and waist circumference respectively, physical inactivity, the psychosocial stress including vital exhaustion, the family history of premature cardiovascular disease like men below 55 years, and we have 45% in our study in the Egyptian Association of Vascular Biology and Atherosclerosis, we find that more patients having 45 years old and have acute myocardial infarction and acute coronary syndromes. The chronic immune-mediated inflammatory disorder. Other factors like majority psychiatric disorders, treatment of human immune deficiency virus, atrial fibrillation, left ventricular hypertrophy, the chronic kidney disease, obstructive sleep apnea syndrome, non-alcoholic fatty liver, all these factors can add on the risk to increase the risk score. Recommendations for cardiovascular imaging for risk assessment of atherosclerotic cardiovascular disease. لو البيشنت ده ما عندوش اي symptoms وما انتش شايف فيه اي حاجه بتعمل له الكاروتيد او femoral plaque burden on ultrasonography should be considered as a risk modifier in individuals at lower or moderate risk. يعني البيشنت ده لو عنده low risk او moderate risk وعملت له الدوبلكس وشفت فيه هنا البلاك بتاعته موجوده ده بيعلى للهاي ريسك. ولذلك we are missing many things in the stratification of our patients. The coronary artery calcium score assessment with CT may be considered as a risk modifier in the cardiovascular risk assessment of asymptomatic individuals at lower or moderate risk. وده الكلام اللي بقوله الدكتور عمرو ان في حاجات missing we should go deep and we should uncover it. بعد كده the cardiovascular disease risk categories based on the score 2 and the score 2OP in apparently healthy people according to age. Low to moderate cardiovascular risk factor treatment generally not recommended. بنشوف الايج اقل من 2.1%، من 50 ل 69 سنه اقل من 5%، more than 70 years less than 7.5%. The high cardiovascular risk بنجد ان below 50 from 2.5 to less than 7.5%. If he's 50 years or 65 years, 5 to less than 10%. More than 70 years from 7.5 to less than 15%. The very high risk are having patients having less than 50 years who have more than 7.5% from the score. From 50 to 65 years have more than 10%, more than 60 years having more than 15%. This is what we should do in order to justify our patients. And this is the slide from the guidelines that show that the very high risk patients are having documented atherosclerotic cardiovascular disease, either clinical or unequivocal on imaging, and documented atherosclerotic cardiovascular disease including previous acute coronary syndrome like MI or unstable angina, or coronary revascularization, عمل BCI أو CABG أو arterial revascularization procedures, stroke and TIA and peripheral arterial disease, ومعاهم diabetes. Diabetes with target organ damage, or at least 3 major risk factors, or early onset of type 2 diabetes of long duration. I should move too fast here. Also, with a high risk are patients with type 2 diabetes without target organ damage with duration of more than 10 years, or having moderate CKD or calculated risk more than 5%. And this are the examples of how to stratify your patient, the asymptomatic patient or the diabetic patient. So patients with established cardiovascular disease and or diabetes mellitus and or moderate to severe renal disease or genetic or lipid blood pressure disorder are to be considered at high or very high risk class 1A. ولازم بعد كده نشوف ده هيصوم ولا مش هيصوم. Stable in cardiovascular disease is a misnomer. What does it mean? Use of more accurate terminology to prevent misperceptions and mistreatment. Stable heart failure is a misnomer. The natural history of heart failure encompasses changes over time. البيشنت اللي عنده heart failure ده النهارده هو في نيها 1 او نيها 2 ممكن يبقى نيها 3 او نيها 4 بيحصل له hospitalization. انا محتاج دقيقتين ثلاثه كده. Improving and stalled or persistent or worsening. نيجي هنا برضه هنا it is important to describe the stage of the natural history and clinical trajectory. الكورونري ارتري ديزيز ما فيش حاجه اسمها ستيبل كورونري ارتري ديزيز خالص. في حاجه اسمها دلوقتي الكورونيك كورونري ارتري ديزيز can have long stable periods but can also become unstable at any time. النهارده انت بتعمل برايمري بريفنشن ممكن بعد دقيقه يبقى سكندري بريفنشن. فما فيش حاجه اسمها كورونا ستيبل. Typically due to an acute atherothrombotic event caused by plaque rupture or elution. However, the disease is chronic, most often progressive, and hence serious even in clinically apparently silent patients. وعشان كده ده prolonged thrombin generation بيحصل في الاكيوت فيز ومع الكرونيك فيز. انا عارف ان الكلام ده كله يعني عشان انا بتاع كارديولوجي وانتوا بتوع دايابيتس، لكن لازم لو فهمنا هذا الكلام والبيشنت هيجي هيفهم. هنا defining the risk for ischemic events. الهاي ريسك بيشنت ده اللي عنده كورونا ارتري ديزيز بيساوي مالتي فيزل ديفيوز كورونا ارتري ديزيز بلس مور ذان 1 انريتشمنت فاكتور اللي احنا قلناهم. لو حطينا الدايابيتس هنا والعيان ده جاي يقول لك اصوم ولا ما اصومش، هتقول له ايه؟ هنا المودريت ريسك مالتي فيزل وديفيوز كورونا ارتري ديزيز او مع مور ذان انريتشمنت فاكتور. بعد كده هنا عندنا الهاي اسكيميك ريسك قالوا البريفرال ارتيريال ديزيز ريكارنت ام اي diabetes mellitus and kidney disease. بالنسبه للادويه بقى هنا انا هقلب بسرعه الكلام ده كله. لما نمسك الناس اللي بتاخدوا ايس انهبيتور او الدوستيرون ريسبتور بلوكرز اللي هم الاربس او بياخدوا الساكوبتريل فالسارتان اللي هو الانترستو او الارني اللي عندهم هايبرتنشن او هارت فيلير، لقوا هنا ان may worsen fasting associated hypotension which may result in dizziness or loss of consciousness, may compound fasting associated dehydration resulting in acute kidney injury, hyperkalemia and life-threatening electrolyte abnormalities, and medication non-compliance may result in uncontrolled hypertension and decompensated heart failure. Take a notice for that. The anti-platelet medications, aspirin, clopidogrel, prasugrel, and ticagrelol اللي احنا بنديهم في الكوروناري ارتري ديزيز وميوكاردال انفاركشن. This medication non-compliance can increase the risk of acute stent thrombosis, myocardial infarction, and death if antiplatelets are not taken regularly, particularly in patients with recent coronary stent implementation. والتيكاجرولول بيتاخد مرتين في اليوم والبلازما هاف لايف بتاعته 7 ساعات. فهنا ده لو هو صايم when taking medication more than 12 hours apart of the effect it may have a catastrophe. بعد كده الانتي اريزميك دراجز لايك اللي بنديها في الاريزميا زي الاميدرون والسوتالول. Some may worsen fasting associated hypotension which may result in dizziness or loss of consciousness. Fasting associated dehydration may result in significant electrolyte abnormalities that may increase risk of AD toxicity. البيتا blockers نفس القصة may worsen fasting associated hypotension which may result in dizziness or loss of consciousness. Medication non-compliance العيان يسيبهم لما بيحصل الكلام ده. كل ده بيعمل worsening للفاستنج. الديجيتاليز digoxin toxicity may occur in potential case of fasting related acute kidney injury. بعد كده الدايركت اورال انتي كواجلانس الدواكس او النواكس دول مهمين جدا زي الابيكسابان وريفروكسابان، دول كلهم بناخدهم في الاتريال فيبريليشن والديب فينس ثرومبوزس 2 times per day. دواكس الهاف لايف بتاعتهم 12 ساعه. if taken in the early morning for example الساعه 3 الصبح في السحور، وبعد كده again for example الساعه 20 في الفطار، there may be a period between where the patient is not adequately anticoagulated. Medication non-compliance may result in stroke and death. loop diuretics, the same, making worsening for this patient, mineralocorticoid receptor, and for statin, also here for the sodium glucose, for the SGLT2 inhibitor for heart failure with diabetes, may worsen fasting associated hypotension, which may result in dizziness or loss of consciousness, may worsen the fasting associated dehydration, resulting in acute kidney injury and or life-threatening electrolyte imbalance, and for example, the hyperkalemia. The vasodilators have the same. So, effect of Ramadan fasting on platelet reactivity in diabetic patient treated with clopidogrel, البلافيكس ده لقوا في الدراسه دي ان بيحصل ان في fasting Ramadan significantly decrease the platelet sensitivity to clopidogrel في diabetic patients, especially diabetic patient, during and after Ramadan, and this effect is possibly related to increase glycemic and of the serum lipids and inducing fasting. Effect of Ramadan fasting على الاسبرين نفس القصه. During fasting Ramadan, aspirin resistance increased only in diabetic patients. This effect persisted 1 month after Ramadan. الناس اللي بياخدوا النواكس دول كلهم لو احنا برضو بصامهم كل دي عباره عن دراسات على الادويه. ولذلك we have to stratify the patient, to study all these drugs carefully, to have a larger data, and we should do in Egypt much larger studies in order to help our patients when they fast, when they ask انا عايز اصوم، تصوم ولا ما تصومش؟ هتصوم على علم، وممكن تصوم بالعلم، وممكن انت تصوم بس لازم تتعلم ايه الموجود. والف شكر.
Thank you, Professor Atef, for this excellent talk.
معلش انا طولت، بس انا كان الدكتوره ايناس قالت لي 20 دقيقه، فمعلش.
Okay, no problem. I would like to ask you one question. Can you brief us in one sentence who is the patient to fast and who is the patient not to fast? Because you presented many aspects and risk factors.
Okay.
So
a patient with acute myocardial infarction ومعاه diabetes او معهوش يعني ماشي، ده should not fast at all. البيشنت اللي دخل المستشفى واتعمل له ريفاسكولاريزيشن وركبت له الدعامه.
Since how many months?
6 months.
6 months. Okay.
Yes. should not fast. لان انا كمان لو هو بعد 6 شهور جه رمضان وهيبدا يصوم واخد البلافيكس او اخد التيكاجرالول واخد الاسبرين زي ما شفنا هيحصل مشكله، لان الستنت ثرومبوسيس دي في الديهيدريشن دي في منتهى الخطوره. خلاص. The patient with atrial fibrillation اللي بياخدهم النيو اورال انتيكواجلانس، هل هياخد جرعتين في اليوم ولا هياخد جرعه واحده؟ لازم اقول له بقى.
يعني بس في many medicines one day once daily.
فانا فهو لو مصر ياخد الجرعتين في اليوم يبقى ما يصومش بقى، لكن هياخد واحده في اليوم ده ممكن يصوم بحذر. البيشنتس with heart failure whatever بقى، heart failure with preserved ejection fraction, heart failure with reduced ejection fraction، الناس دول بيخشوا المستشفى ويطلعوا من المستشفى يعني ممكن يقول لك انا عايز اقعد في المستشفى 6-7 شهور، لما بتعمل له اللينس اوف ستاي ب6 ايام وتخرجه بيشتكيك لانه مش عارف ان هو مفيش فده اعتقد ان ده ما يصومش.
Yes, okay. يعني this in summary patients with acute cardiovascular event.
تمام.
تقريبا كده الملخص يعني. اللي
هم ما تقدرش بتحكمهم. الناس بقى اللي هم عندهم كلمه ستيبل انجينا دي غلط، لان الكرونيك اللي هو الكرونيك سيندروم ده ممكن مع الوقت يحصل له ثرومبوزيس على طول، فده لازم نبقى حذرين. البريفرال سواء كانوا فينس او كانوا ارتيريال دول برضو لو بياخدوا ميديكيشنز مع الديهيدريشن مع البرولونجيشن بتاع التايم بتاع فاستنج can have the thrombosis.
Okay, thank you very much. Any questions please? Yes, Professor Amr Apoham.
This is not a question, rather a comment. The problem is this patient has a cluster of risk factors. He is not only with ischemic heart disease, he is not only with chronic renal disease, he has not only diabetes, the clustering of risk in a certain patient, this may raise the doubt about his ability about to fast or not. The risk should be taken together, not an absolute single condition. The risk should be evaluated in the context of all risk factors he has.
Okay, I would like to ask you a question, please. Okay, about your presentation. You mentioned in one slide the very high-risk patients, stratifying them that if they have diabetes and 3 risk factors. Okay, I think I remember that.
This is European Society.
Yes, yes. I would like to ask. I think most of the patients with type 2 diabetes have hypertension and have hyperlipidemia.
This class.
So these patients, most of them, can they fast or not?
This is
If you controlled hypertension, controlled dyslipidemia.
I give this example of a patient which by current guidelines, except of our guidelines currently in progress, that this patient by the AASD or ADA or DIDAR is safer to fast. If I told you that this patient has left ventricular hypertrophy, still he's safe to fast. If I told you this patient is living hot climate,
I think this is the missing point which you raised.
no.
This is the missing point.
This is the missing points. Okay, how do we identify the patient with diabetes without evidence of macrovascular disease? Here I presented a part of the solution that we should look to the microvascular complication. If it is present or clustered, we should not accepting for this patient to fast. Dr. Atef said that we may add the carotid intima sickness as a risk factor. If it is increased, we can discourage this patient from fasting. So it is too difficult. We are now studying the researches from many societies, many authors, so we can characterize how we can help this patient, whether he is going to fast. If he insists to fast, we are developing now the idea of safe fasting. What we can do as a diabetologist and cardiologist and a nephrologist for patients who insist to fast. We just tell him, no, you go fast.
And the polypharmacy, Dr. Amr, the polypharmacy, he's diabetic, hypertensive, ischemic, and having heart failure, having chronic kidney disease. The polypharmacy, how can we manage all this all together? Who can do that? Who can guarantee for all of us, whatever, for vascular medicine or vascular surgery, that the plaque will remain stable? It ruptures at any time.
Yes.
It ruptures at any time. So no stability.
Is going to comment on this.
I will comment on the carotid duplex finding that the intima media sickness since 30 or more than 30 years was proved to be one of the risk factors of generalized atherosclerosis, whether coronary, peripheral vascular disease, but not a high risk for to prevent or to tell him not to fast. He is a risky patient, so he should be followed up.
الكورونري ارتري كالسيوم سكور
Okay, we have some professors online.
اللي هو السي يس يعني الكالسيوم سكور ده ادنج على البيشنت دول. تمام.
Professor Hazem, would you like to comment on these two lectures about the risk assessment scores regarding advising patient to fast or not to fast? And regarding the cardiovascular...
thank you very much. Yes, thank you very much, Dr. Inas. Dr. Atef, thank you very much. But there is, I want to comment on one thing, is that on most of the guideline for a diabetic patient, usually a patient who is asymptomatic regarding the cardiovascular system there's no need for doing any investigation. There is no need for ECG. There is no need for echo, for stress test ECG. And now you are telling us that some patients who are asymptomatic, you can go and do for them carotid Doppler and to measure the carotid, the intima media thickness.
Any patient comes to your clinic, the first from the guidelines you have to do the ECG, electrocardiogram, you have to do an echocardiogram, you have to make the lab test, including lipid profile, chronic kidney disease, serum creatinine, EGFR. We should have all this data, but to enrich the risk factors and to add on and to change the risk factor from one block to another block is to do the carotid ultrasonography or the coronary artery calcium score.
Professor Shahinez, would you like to comment on these two lectures?
Dr. Atef, العفو, guideline wise,
Yes, thank you.
it is not indicated to send a patient for full cardiac study if he is asymptomatic. Yes, if he is symptomatic, okay. He has to go for full cardiac study. Thank you very much.
Thank you. I have two, one comment and then one question as well.
There is echo, we don't...
My comment is this risk stratification is very important, and both of the speakers have very nicely emphasized this. There should be a detailed risk stratification, and also we need more long-term studies, because as Professor Amr emphasized, most of the studies are carried out around the Ramadan time, so just before, and then some other measurements at the end of the Ramadan time. So we need longer studies with more participants, of course.
Yes, we need it. Yes.
And then the other thing is we have the same problem in Turkey. The thing is, although we usually we do not recommend fasting during Ramadan, but but if the people want to fast, we try to give them suggestions and some comments, because even we say please don't fast, they do fast. So therefore we should help them to go safely through the Ramadan time, especially the people with several risks. So therefore this is a problem also in Turkey.
Yes.
My question is about this year and also the last year, the COVID problem. Because even we say that some people may have low risks, but still the COVID, the number of the COVID patients are too high in Turkey, and from what I follow from the World Health Organization, also in other countries in our geography. And we have now more and more people with thromboembolic events, even after months after the COVID. So do you have any suggestions or anything, about the COVID and with diabetes plus the fasting, Ramadan fasting?
Yes, I got your point. We still need more informations, because we face many problems with the vaccination, with the COVID itself, with myocarditis, and for the pulmonary artery thrombosis. And those patients are poor. And if we collect the data from China to Turkey to Europe to Egypt, I think those patients who have events after the COVID, they should not fast Ramadan, and they must be under observation. This is my opinion. But if he's able, he should have not to be dehydrated. He should follow a doctor. he should stratify his lung, he should measure the pulmonary artery blood pressure, he should examine the plasminogen inside his blood. Many things should be, but we don't have any data.
Currently, the group of investigators in AASD are studying the incidence of macrovascular complication and hospitalization for macrovascular complication during the 2 years from the, it's a retrospective study, during the 2 years, year 2020 and year 2021, and we are just waiting for this Ramadan to conclude our study or research about the incidence of this macrovascular complication prior to COVID, prior to Ramadan and during Ramadan and after Ramadan in the COVID era. So you can ask us about this study. It is an ongoing study, waiting for the results, final results to publish, inshallah.
And I believe that our Allah is more merciful than us, because we are doctors, we are human, and we are trying to say yes or no. But if you find yourself, for the patient, are not able to fast, Allah give you a license, and you have to accept it. And this is what I if
Thank God,
yes, yeah.
inshallah, when
Inshallah.
Ramadan come after 2 or 3 weeks,
Yes.
This epidemic or this pandemic
We hope
will
so.
be controlled.
We hope
and,
so.
We will all fast.
We hope so.
Of course, the post-COVID syndrome, it may persist up to 6 months.
Yes, more
And
than
in
6
this
months.
group of
More than
people,
6
they
months.
shouldn't fast.
Yes. Yes.
Professor Chaplin, would you like to comment on the 2 lectures that have been mentioning regarding the risk factor stratifications and fasting on Ramadan?
Thank you very much. It's a pleasure to be here, and there were so many things that I also learned from the lectures. They were really good lectures. What I mean to say is that we in MENA region should have our own guidelines for cardiovascular, pregnancy, and renal problems. Because we rely more on the Western figures, so that is not fair. And in Pakistan also, no matter how bad the health of patients are, they would insist on fasting. And another problem is that the doctors, they feel very bad advising them not to fast. They think that they may be committing some sin, or they may be not right. So the doctors also need to be taught that what are the true Islamic rulings, and what should they follow according to their medical conditions. So it needs 2 things: the education of doctors in Islamic and medical perspective, and also the education of the patients. And for this, we need specific guidelines for MENA region, because our patients are absolutely different from what the figures are coming from the West. Talking about the pregnancy, which was very nicely elaborated by Professor Inas, I would say that patients are afraid that their child might become hypoglycemic. Generally speaking, we advise them not to fast. What to say of pregnant women who are pregnant and diabetic as well? So there's a big no to pregnancy and diabetes to fast. But yet, as I said earlier, patients do not comply with what we say. They think that it is they will miss the chance, and they don't feel good not to fast. So in that case, the fear that the child would become hypoglycemic, if the woman becomes hypoglycemic, is unfounded, because the child can survive, the fetus can survive with a blood sugar of less than 40 milligrams per dl intrauterine. So the fear that the child may become the fetus may become hypoglycemic is not founded. And the woman, there are different recommendations for the woman who is pregnant and wants to fast. Like in the first trimester, second and third trimester, there are different recommendations. It is relatively safer to fast in first trimester if the woman is not having nausea and vomiting as compared. And these days, when the hours of fasting are too prolonged, the risk of dehydration and the risk of preterm labor are there. So we recommend, we ask the women not to fast if they feel dehydrated. And the important thing is that they should be encouraged to break the fast if they feel dehydrated, dizzy, or feel less fetal movements. So thank you very much for providing me this opportunity to share my views and to learn so much from the learned speakers. Thank you very much.
Thank you, Professor Shabin. Only the last comment, Professor Dr. Nada. تفضل يا ندى.
أنا ليا سؤال صغير. شكرا على المحاضرة الرائعة دي.
مايكروفون يا معلم.
حضرتك قلت إن العيان الهارت فيلير سواء كان reduced ejection fraction أو preserved ما يصومش. طيب إحنا بنعمل إيكو. ناس كتير جدا عندهم diastolic dysfunction سواء كانوا hypertensive أو ischemic ومش لازم يبقى عليهم المانيفستيشنز الكاملة بتاعة الهارت فيلير. الناس دي تصوم ولا ما تصومش؟ شكرا.
متابعة كويس. في الهارت فيلير بريزيرفد ايجكشن فراكشن اليوروبيان سوسايتي اوف كارديولوجي والامريكان كوليج اوف كارديولوجي حطوا سكور سيستم. العيان ده لو اوبيز هايبرتنسف عنده اتريال فيبريليشن، موضوع الايكو ده ان احنا بنقيسه ده برضه مس نمر. انا اعمل ايكو اطلعه ايجكشن فراكشن 44، حضرتك تعمل ايكو تعمله 45، الدكتوره تعمله تقوم جايباه 60. فده ما هواش ده فاريبل وما نعتمدش عليه اطلاقا، بنعتمد على البيشنت اللي قدامك ده بالسكور سيستم محطوط كده قدامه. واليوروبيان سوسايتي اوف كارديولوجي حطت السكور سيستم معقد كده شويه عشان تقيسي حاجات جوه الايكو بقى مالهاش علاقه بالايجكشن فراكشن خالص اللي هي
يعني حضرتك الديجري اوف diastolic dysfunction may help in the scoring. If it is grade 1 this is a safe situation. But if it's grade 3 or 4 you have to reassess the situation regarding fasting because this
أنا
patient.
بتكلم على ايه؟ العيان ده انا هحكم عليه هيف ريف معناه الايجكشن فراكشن تحت ال 40 ونازل خلاص لانها اتقسمت.
No with preserved ejection fraction.
لكن ويز بريزيرفد ده عندي لحد ال 50 في الفيميلز وطالع كده يعني من الاول ال 45 لحد ال 50 في الفيميلز. الفيميلز مختلفين في الايكو عن الميلز. لكن واحد مثلا اوبيز وعنده اتريال فيبريليشن، عنده دايابيتس، عنده ديسنيا وارثوبنيا وعنده اديما لور ليمب وعملت له الايكو لقيته 60، ده يتحكم عليه يتقال له ايه؟ فبنحكم بايه؟ بناخد السكور والسكور ده لو اكتر من عدد معين يبقى ده العيان ده عنده هيف بيف ويعامل معامله البيشنت العضو الفقري. عملوا بقى حاجه دلوقتي كده جديده وهتتعمم في كل المستشفيات ان انا اقيس الماركرز بقى هو برو ان بي بس كده. لو زايد ده ماركر على طول ان ده عنده هارت فيلير يبقى ده مش هيصوم على طول.
Thank you for these very rich lectures and very rich discussions. And thanks very much for Professor Shahinaz, Professor Hazem from Iraq, Professor Shahinaz from Turkey, and Professor Shabin from Pakistan. You are welcomed to continue on the second lectures, inshallah. Thank you very much. We close this session and we start the second section, the session 4.